So there's something to be said for us going through upper eval, lower eval, and then you start getting head, neck, and spine, and you're hitting a realm in which it's emergency medicine. How you manage these things becomes inherently important, imperative to the survival and the safety of these individuals. I've lost one athlete in my 11 years working as an athletic trainer. She had undiagnosed diabetes. She went home, went into seizure after practice, and she never came out. She never came out of the coma she went until she passed away. Head injuries I take very, very seriously. Now, and there's a little bit of a catch there, because are we better at diagnosing them? Are we better at recognizing what those symptoms are? Are we more protective? I think we are at all of those, and so we see them more often. But we don't have this definitive way of identifying that, yes, you have a concussion, no, you do not, you're just faking it, get back on the field. And that's part of the problem, because kids, especially 14-year-olds who don't want to play football, or whose dads are making them come out there, they learn the buzzword. The golden ticket is a concussion. It buys you at least a week out, if not two. And that's where the way a lot of coaches will look at it as well. How can you tell? And he's just playing you. Well, I get it, but what do you want me to do about it? Because I'm not going to end up with one of these problems. It hurts me to sit there and watch that deposition with that athletic trainer. I don't understand how, with what we do, how he referred this individual to a nurse who doesn't work with concussions. How those policies are arranged that way. I'm not faulting her. It's not her background. It's not her experience. That's not her job. It's the athletic trainer's job. I don't know how their policies and procedures allow that to be passed along in those manners. So how you set policy and how you approach your facility, your athletes, the people you're working with, it matters. Getting good at what you do matters. And so how is it, we talked about last time, that it's really based on symptoms. We've had every 4 years, there's an international consortium of the top researchers and medical professionals in the world. They get together, Zurich, Prague, I'm not sure which one we're on, but it's 2012 was the most recent update. And everything says you assess, make sure the symptoms are gone. And then you can do a day-by-day progression to get somebody back in. It took me 3 months to get a kid back in one time. Because we'd get him in, I'd put him to where he would do light cardio one day, that would be fine. The next day he would step it up to do more intense with some sprints, and that would bring the symptoms back. Well, that puts us back to where we have to wait 24 hours for the symptoms to go away before I can start the progression again. And with him, it took 3 months. His brain just wasn't recovering well. And so we had to pull him out. Because I was his second concussion that season, and that second one, it just wasn't healing. So it's a big deal. Effectively, you have this massive vasodilation, you have this massive edema that comes in, and you end up with brain swelling. And they can usually die faster than you can get them to the hospital. So it's pretty intense, and there's not much you can do outside of load them and go. Yeah.
In the video, it said that it happens under the age of 25, I believe.
For under the age of 23.
So second impact syndrome can't happen after that?
It doesn't happen with older individuals. So you won't see this happen with like NFL players as long as they're over 23. You just don't see it.
Okay.
So for them, they would just get the concussion, they would get all they would.
We're looking at multiple concussions, which has its own consequences, but you're not having the sudden brain swelling. So it's just in high school and college athletics that we have these concerns. And they don't know why. And so that's a lot of that up in the air about. And there's even some out there that say second impact doesn't exist, but then you get these cases, and these cases exist. And the cases of people dying from it, from this massive cerebral swelling, exist. So,
And he wouldn't have survived if the hospital wasn't so close?
no, he wouldn't have survived. I don't believe he would. I mean, if you've got another minute, 2 minutes worth of that pressure building up, your brain function stops functioning, and it starts destroying the brain stem, which destroys all of the auto-regulation for breathing and heart rate. I don't think there's any way that would have. Just sadly to say, I don't think it would have gone as well as it did. So. Inhibited cranial nerve function. So anything you assess is going to be problematic. And we're looking at optic, oculomotor, olfactory, you start pulling any of those in there, and there's going to be some deficiencies that are showing up pretty quickly. The ability to track the eye, let alone see clearly, the pressure that's in the system is crushing the nerve. They're not functioning right. Impaired cognitive processes, again, it's compressing your cerebral cortex, so your nerves are not going to be able to function the right way. And then rapid deterioration of vital signs. It's going to happen pretty quick. So what we've got is, so immediate management, what do you want to do? If this person's on the ground, you need access to their airway. So if they're in football gear, lacrosse gear, you manage their equipment the way you need to. So lacrosse, you can remove helmet, you can remove shoulder pads just fine. Those things are paper thin. Football gear, you've got to pop the face mask off, have a drill ready, unscrew it, pull it off, then you've got access to airway. And you start CPR. You start managing those symptoms to make sure that the paramedics, when they arrive, can intubate. So if you do suspect it, it's a 911 call. I mean, if this person's down and out, then you get them a call. So is it the concussion that I'm worried about? So what can you tell me about a concussion? What? Not so much blood clot. It's bruising.
Vibration of the brain.
So this guy had a blood clot that somehow manifested from,
what was
they were saying there's a massive blood clot they had to remove. Concussion it's that jarring force. The terms coup and contra coup, have you heard those?
Mm-hmm.
Yeah, so the bruise on one side, the rebound bruise on the other, so we're impacting the brain in two different locations. We're bruising the brain. What have you heard about how to manage one? What are rules? Don't go to sleep.
I heard otherwise.
Reduce function.
I heard otherwise. It's okay to go to sleep.
No reading, writing, or intake.
It's gonna do.
Okay. For how
Well, I'm
long?
not gonna fall asleep.
Yes.
Listen to stop. Let's talk about these things.
Reduce
That's
activity.
for all of this. So what is it about, why can't you go to sleep? You're just not going to wake up because you have a concussion? That's really what most people think, right? Because you're not going to assess symptoms. So it's not, the concussion itself, once I hurt your brain, once you hurt your own brain, the damage is done. You go to sleep, it's fine. It's not going to hurt. You're going to wake up. Concussions are concussions. They're not good. They leave you dazed, they leave you confused. You ever had one? Anybody here had a concussion? They're fun and happy. You feel that warm, fuzzy feeling all over, and you're like, yeah. You can't focus. It's like, the term is living in a fog. Yes? It's just, I don't know. There's something to be said for this. You're just in a fog.
I thought I fell asleep for because I got kneed in the head.
Yeah?
And I thought I fell asleep
That's
for
what
for 5 minutes. And my teammate said I stood like this because I came out for a ball like this. And I stood there for 30 seconds and I thought I fell asleep for 5 minutes or 5 hours. Just like this.
Okay. It's not the concussion that I'm worried about. With just a concussion, you can go to sleep. That's not my concern. My concern is when we have secondary problems. So we can take second impact syndrome out of this conversation. That's going to happen almost immediately. So if there's something they didn't tell you about, if that's hidden or wasn't managed right and they get to the hit, that will progress very quickly on the field right then and there. So 5 minutes into this conversation with this concussed individual, and we can rule out second impact syndrome. Vitals are normal. They're still talking to you. They're dazed. They're confused. They're concussed, and you're assessing that. But we can rule that out. The next steps we have are epidural and subdural hematomas. Because that's where we start getting into some scary stuff as well. So, epidural hematoma, epi means above, right? Most commonly middle meningeal artery. So what can you tell me about an arterial bleed? What's driving that blood?
Heart.
Heart, right? So we have a positive pressure pushing out between 120 systole over 80 diastole. We've got pressure driving this system. And it's probably elevated because they've been playing sport. So their heart rate's elevated, and then we have an injury on top of it. This is a fast bleed.